Great. Thank you for telling me because the three other ways that I checked, I thought I wasn't in a room.
Good. So good afternoon, everyone. Dr. Guiley got interested in taking a look at guidelines for transfusion, specifically of packed red cells, after kind of noticing, like all of us did over the years, that sometimes the practices vary perioperatively. Sometimes people will have different criteria for getting a type and screen versus a type and cross. And then intraoperative management sometimes varies. So he's going to take a look at a lot of society guidelines and then hopefully give us some of the data too that was back there from the NIH, etc. So Julius, thanks for being here.
Yeah, thank you. Thank you everybody for coming. I'll go ahead and get started. So by the end of this talk, I will try to cover these objectives, general principles guiding decision to transfuse packed red blood cells, and then the thresholds for transfusing based on hemoglobin, and look at some of the society guidelines and see if there is any variation or if they have the same theme. And then touch based on the transfusion risk, strategies for minimizing the need for packed red blood cell transfusion. So in this talk, I won't focus on pediatrics, not go to the handouts. No cardiac stuff, no transplant, and no trauma or situations where you need MDP. So basically, electric cases. So transfuse or not transfuse is everything based on hemoglobin. Well, to some extent, I think most people we kind of have that in our background. Anytime we look at the labs, like hemoglobin 7, so starting about transfusing. One actual, some of the cases might not be the ideal scenario. You might be able to get it by without transfusing. So common scenarios are either like hemoglobin of 7, you're going to transfuse if someone doesn't have cardiac disease, or hemoglobin of 8 for those who have cardiac disease. Try to keep the hemoglobin around there. And then for liver transplants, or those people in liver transplants, or in some other scenarios where the surgical team wants hemoglobin above 10. So the question is, where do these numbers actually come from? How did people end up with 7, 8, 10, or whatever number they throw around? So the basics of it, we can think of blood cells as a way of delivering oxygen to the tissues. So basically, it boils down to oxygen delivery. And this is the equation which shows all the time on our exams. And basically, all the variables are there: stroke volume, heart rate, and hemoglobin, which is our focus. So a lot of variables that you can play around with to see whether you can still get oxygen to the tissues. Keeping in mind that the body has a lot of redundancy. So the system is designed that you're actually supplying 4 times more than what you need at rest. During anesthesia or during stressful situations, it might be different. Of course, you need more. But then the question is, how more do you need? If you look at the other patients, so the simplest way or the quickest way of compensating is increasing your cardiac output. Just looking at the equation. You increase one variable, then of course you're going to increase oxygen delivery. In the critically ill patients, that might not be the scenario. They might not be able to mount enough compensatory mechanism to increase their cardiac output to compensate for any changes in hemoglobin or in stress-related situations. And also, they're also consuming more oxygen than an healthy individual. So in that scenario, then the oxygen hemoglobin also comes to play. Their numbers, if they increase, then they need to be adjusted accordingly. So far, looking at that equation, you can play around with a few numbers here and look at what happens if you change a few of the parameters. So assuming a healthy person, hemoglobin of 14, it's 100% saturation. You are basically delivering 20 mLs of oxygen per deciliter. So deciliter is, it's a 10th of a liter. So if you convert this, will be like 200 mLs of oxygen per liter. And if you assume a cardiac output of 5 liters, so that's almost 1,000 mLs of oxygen. So in a normal person, you're delivering like 1,000 mLs, when actually you require at best like 250. So basically, you have like 4 times buffer to be able to play around. So if you drop the hemoglobin to 7, you'll actually end up delivering 10 mLs, which will translate to around 500 of oxygen, which you are still like twice the amount that you need at rest. But then if you actually under anesthesia, then you need more than 250. So you're actually requiring more, but you still have a big bungo room. Other scenarios like if you have a lung disease and you're not actually able to get enough oxygen tension, if you are running around this number here, then still delivering still higher than what you need at rest. So generally, making a decision about transfusion is not just about hemoglobin. And as you prepare for cases, if you have elective cases, it's not somebody who's coming in bleeding right away. You're actually having time to plan for it. You can think through some of the things that you can anticipate. What's going to be the blood loss for the case? And then how much are you starting with? What is expected of volume for that patient? And what is hemoglobin? Keeping in mind that could be in concentration, so the number might not be what it is. And then what are the other comorbidities? And the rate of blood loss. Will you have enough time to be able to do that typing across, get the blood to the room, or you need to have the blood in the room? And does the patient have any antibodies? That may take longer to get blood, and availability and access to the blood contacts when you're doing the case. So in this kind of scenario, and what I'm aiming at is, apart from looking at the hemoglobin, there's no question of if you need the blood, will it be available on time? And that's where the scenario of like testing comes in. Do you need actually to test, or do you need 500 cross? Which was my whole idea of why do people just say like let's test or let's type on a cross for this hemoglobin? Only if you're in a center where you can actually get the blood at when you need it, within the shortest time possible. And unless it's a vehicle which is backing out and the surgeon can't put a hand on it, would you have enough time to type on a cross and get the blood in the room? So these are some of the things that you think through when you're preparing for the case. Blood is not benign. There are risks with it. Immunological, trolley, tackle, GVHD, infections, and hyperkalemia. I actually quoted some of the infection rates that quite low, but I mean the risk is still there. Hepatitis B is common, followed by C and HIV. And these numbers actually get better with more testing, especially the HIV and with viruses because of better modalities of testing. So the question is, what is optimal hemoglobin, and what do we come up with those numbers, like deciding on 7 as I say? I looked at one of the study, which was in Transfusion Journal. So this study was actually a retrospective study of 203 patients. And those patients were not transfusion candidates. Actually, the majority of them were job as witness who, let's say, they won't get blood, whatever the case. And it was actually one center at New Jersey, Eagle County. So they looked at the study, which was actually a follow-up on a previous study, which was done in 2002. So they looked at all the patients who underwent surgical procedures with the exclusion of open heart surgeries, but any other surgery was part of the play. All the patients were above 18 years old, and they at least needed to have an hemoglobin of 8 or stop, and no blood transfusion. And the primary outcome was that the mortality. Secondary outcomes were MI, pneumonia, sepsis, and wound infection, and CHF. So overall mortality was 8.2, compared to 10 years earlier what they found, which was 9.4. Keeping in mind, actually, some of the patients are more sicker than them, and the mortality actually went down about compared to 10 years earlier. And then when adjusted for odds ratio, an adjusted one was 2.4. 10 years earlier on, with Kazan, we had done the same study, was 2.5. And then when they adjusted for things like acute angles of the case, age, and cardiac diseases and all that, It actually went down to 1.2. So there is still some significance, and this odds ratio for any drop in hemoglobin below post-op hemoglobin. So if you came out of the OR with hemoglobin of, let's say, 8, you drop 1 gram lower than that, within that day period, that day's period, you actually get a risk of 2.5% of cardiac death, mortality. So this graph actually just shows basically the probability of survival at given levels of hemoglobin. And the most important thing is, and that's why it alludes to the numbers where they're coming from. If you get to hemoglobin of 7 and 8, you're almost actually at 1%. You almost guarantee survival with that kind of level of hemoglobin. Keeping in mind, we're not saying anemia is actually what is killing you. It could be just a point of, it could be a factor like, it's not necessarily the reason why you're dying, but the cause of the anemia could account for it plus other comorbidities. But regardless, if you take care of the other confounding variables, anybody with hemoglobin of 7 to 8, survival is almost 1. So by trying to transfuse beyond 7 and 8, you are not actually getting any mortality benefit based on this study. But again, if you drop it to like 5, 4, you actually, the graph starts changing like very steep increase in the risk of mortality. Then actually the study mentioned at 2.5 hemoglobin, you almost have 50% chance of dying. So the question is, what is optimal hemoglobin? So some studies have shown for sure hemoglobin of 5, you start seeing EKG changes, which is indicative of myocardial ischemia. You also start seeing a cognitive decline in that level of hemoglobin. You don't lose the long-term memory, but actually short-term memory is in there. And then oxygen carrying capacity does not necessarily equate oxygen delivered to the tissues. You could be able to deliver oxygen using hemoglobin and all that equation we are showing, but if there are other underlying factors that you are not able to utilize it, then that will affect it. And that's why the critical care patients come in. Like you're able to give, they need a high hemoglobin level to be able to deliver more oxygen so that they can be able to use it. And then this is just a repetition of the prior slide. Mortality post-operatively starts to decrease, to rise from hemoglobin of 7 and going down. And aggressively transfusing beyond hemoglobin of 8 does not necessarily improve mortality. So some of the guidelines from different societies that I looked at, ASA, American College of Obgyn, and then Association of Blood Banks. So way back in 2013, ASA put out a statement of 5 things that physicians and patients should question. So number 4 on the list of the 5 things was transfusing somebody who is young with hemoglobin of more than 6, without an ongoing blood loss. It's questionable. So basically they're advocating for hemoglobin of 6. As long as you're hemodynamically stable, if you're symptomatic, you don't need to transfuse it. What about the other 5, the other 4? The things that we should question? An idea? I'll actually show them up. So don't obtain baseline labs studies on patients without any significant systemic disease. Somebody who is healthy, you don't need to take in labs, and that's the same issue again of typing and crossing. You don't even need that CBC. You don't need to see that hemoglobin to begin with, so you don't even think about the typing and crossing. And then basically, you don't need to do a lot of other testing if somebody doesn't need that. So they put out a practice guideline 2015, which basically suggested multimodal protocol and using algorithms to make a decision about transfusing. To be able to justify to transfuse for somebody who is within the gray zone, 6 to 10, you need to look at all the data. things like how are you oxygenating, what are your hemodynamics, what is your base deficit, and basically what are the information you need, not just based on the hemoglobin alone. And then if you are transfusing, you don't need to just keep on pouring the blood unit by unit with the evaluation of the response from the transfusion. And those patients who are bleeding, if you actually transfuse because somebody is bleeding and because of coagulopathy, then think about correcting the coagulopathy instead of continuously just transfusing. Consider using antifibrinolytics, TXA, and the likes to minimize the bleeding. That way, you end up not transfusing. And then try to do hemodilution could actually help with transfusing. That's just using the physiological way of like expect and that is what happens. The hemoglobin tend to become anemic just from the hemodilution. That when they lose their blood and they actually have and then college of physicians and gynecologists, the same statement: do not transfuse somebody who is stable, asymptomatic, with hemoglobin of between 7 and 8. And then, so the American Association of Blood Banks actually did, they had more thorough recommendations based on multiple randomized trials that they looked through, and I'll go through some of them. So they looked at 31 randomized control trials involving 12,000 patients, comparing restrictive versus liberal transfusion. Restrictive meaning not transfusing below unless the hemoglobin was less than 7 versus liberal above 8, 10. And then they also looked at the range of the blood being transfused, fresh versus transfusing the blood within the lifespan. So fresh meaning within 10 days versus just transfusing at 10 given point. The key is actually most of the blood that we get, its average is 19 days. So although it's good for up to 42 days, most of the time we end up transfusing before it's actually nearing the end of 42 days. And then all these randomized control trials were involving surgical patients or medical patients, including patients with critical care units. Again, the primary outcome was lifetime mortality. And then secondary outcome was non-fatal MI, pulmonary edema, stroke, and CHF and metabolic events. So what did they come up with? Don't transfuse. I mean, hemoglobin of 6 is, I recommend transfusing, except in exceptional circumstances. Probably someone who is sickle cell anemia, someone who has been stable with, overloaded at 6, potentially could get along with it. Hemoglobin of 6 to 7 is generally indicated to transfuse. Hemoglobin of 7 and 8 for patients that are going orthopedic surgery and cardiac, I recommend it. And then 8 to 10, generally not transfused, unless the concern is ongoing bleeding or somebody who has acute coronary syndrome. And then hemoglobin above 10, highly recommended not to. Unless, of course, if you are talking about somebody who is continuously, I mean, somebody who is bleeding or anticipated big blood loss. And then American Society of Hematology, the same story. Don't routinely transfuse patients with sickle cell disease for chronic anemia or uncomplicated pain crisis without appropriate clinical education. And basically, their pain crisis will resolve with giving them more fluids and managing the pain. So my conclusion on looking at all these, the evidence gained, the numbers that we get, and testing for blood products. So don't just base it on hemoglobin alone. If somebody has been stable at hemoglobin of 7, and you're not worried that they're going to be bleeding continuously, is a bleeding that is controllable, then you don't need to transfuse them. It might be reasonable to type on the screen, transfusing is not might not exactly get you what you want. Employing blood conservative techniques to minimize allergenic transfusions, which would include things like acute normovolemic hemodilution, reversal of anticoagulation if it's feasible to minimize bleeding, and again use of antifibrinolytics to minimize excessive blood loss. And then you can consider using autologous blood donation if that's feasible logistically, or if you are anticipating critical blood loss. And then you can try to treat anemia if it's an elective case and there is time for it, especially if it's a renal patient who can benefit from erythropoietin or even iron. Then again, blood cell and withdrawal. So as you look at the hemoglobin, look at the other factors which I actually mentioned earlier on. Hemoglobin included, but base deficit, coagulopathy, oxygenation, and try to correct for those. And then again, clinical symptoms. If somebody is asymptomatic, then you can verify with it. Otherwise, if they are symptomatic, tachycardic hypertension, then it may be transfused. But overall, the general consensus is don't transfuse is less than 6, avoid it is more than 10. In between is a gray zone. Will this change my practice? So I use hemoglobin as a red flag, just to tell me I need to look more into it, get more data points, and plan accordingly. And then transfuse based on clinical context, not just hemoglobin alone. I'll take any questions.
On that slide with the AABB guidelines a few slides back, did they say what were the exceptional circumstances in which they would not transfuse for a hemoglobin of less than 6?
They mentioned about like a sickle cell.
Okay.
Yeah.
Just curious.
Julius, really nice talk. So when you take a look at the boundaries that many of the guidelines use, including ASA, from 6 to 10, healthiest of patients probably are going to need under 6 to be transfused. Above 10, the sickest patients don't. Comes from data out of the NIH a couple of decades at least ago. What I'm curious about is when you were taking a look at the guidelines and the clinical indicators in that range, was there any clinical indicator that stood out as being either more common or more important, such as refractory hypotension, EKG changes, etc.? Anything?
None of the studies actually pointed on anything specific. The only that came out is cardiovascular disease. Those patients who have other comorbidities, specific cardiovascular diseases, then there is more of the studies recommended trying to transfuse them at higher hemoglobin level than anybody else. The rest of the other patients, regardless of their tachycardic or they are becoming asymptomatic like hypertension, the goal was actually you try to support their hypertension without exactly transfusing. The key transfusion was based on were you going to lose more blood, or you if you're not losing more blood like than you would expect, then you actually don't need to transfuse. You can support their blood pressure with other means without transfusing.
This is a question for you, but also for everybody else. You mentioned earlier when you have that table looking at oxygen delivery, and you say that the 250 cc's of oxygen per minute is what you need at rest. How did they get to that number? Where does that number come from?
Probably testing medical students.
Like the actual calculation, like modulation, like comparing if you compare your mixed vein as oxygen and your arterial, then
So that's one way compared to within one patient that you can detect that.
Yeah.
But that number actually comes from studies that were in healthy men, white men. There are some people that think that it's not a number that is really applicable necessarily. And so unless you have a PA catheter and you're able to actually look at what that extraction is, you don't really know. And so so that's why it's an important thing to keep in mind. Like for the tests, you have to remember that number, but clinically you have to put it into context. And so most of our patients we take care of, we don't have a PA catheter in place. You're not looking at what their mixed venous saturation is. So you don't know for certain. And that's why you have to use all these other clinical indicators to decide whether you're delivering oxygen at the level that you need to.
Question? Okay, thank you.
I got my stuff. I didn't realize.
What's happening on me right now? What?
Okay, let me see the address.
I wear my white.
When I looked, that's when I got. Because it's getting sized. No, it's getting sized.
We had Dr. Seltzer.
He got me sized. He got me, no, literally no. He got me a size 8. And I was like, I wear a 4 3/4.
I'm like a 6.5, and I have like bare paws.
Dude. Where's this picture I took of the board one day that Monasteros wrote on? So pretty.
Wait, you didn't dress up all the time to
His mom apparently is a British royal. Oh, yeah. I was so lucky. His mom is directed descendant of the British royal family, which I don't know. This is some my engagement ring. And this is someone's somebody, his mom got the husband.
It's alright. So are you gonna be like,
So I'm like basically
20 million in line?
Basically human. It's basically a royal child. Some sort of distant cousin of the Princess
Lady
Charlotte. Lady Grey. She's like his mom's like great grandma. I was like, how did I not know this earlier?
Great.
Could have been using this
Would have been
information
pregnant
for
earlier.
other things.
Yeah, no.
I basically can call people peasants. Yeah, I'm gonna wear a band every day because something is yes, it's like yeah. So I've got a tip for lesbian. I'm gonna do it every day. Get it dialed in.
As of the Quasho tomorrow.
May the 4th, which is Star Wars Day. We were both like,
The normal
my brother-in-law was like, I think you're like,
Really?
Oh,
it's exciting.
I'm excited. I love him so much. He's so wonderful.
Good.
He's so sick today, but good.
Yeah.
Yeah, everything's normal, good. All the, we got all this tests, but everything's good. Yeah.
Are
Shocker.
you eating turkey?
No, I have listeria. Shocker.
We're going to go ahead and get started.
Oh, yeah.
Dr. Antonovich, your lecture.
Yeah. All right. So I'm going to talk about perioperative management of potential cardiac devices. I did this for multiple reasons. I heard feedback from a couple of attendings that we tend to struggle with this topic, and I know that it's pretty complex. And not every situation is the same, so I want to try to simplify it, kind of give an overview of some of the considerations that we need to some of the things we need to consider in the perioperative period. Thanks to Dr. Clendenin, who took a look at my slides and gave me some suggestions along the way. Let's go ahead and get started. So the goals of this lecture is to know the basic function of CIEDs, or cardiac implantable electronic devices, learn strategies for their identification, identify perioperative considerations for their management, and to develop an approach toward a patient with a CID, whether it's an elective case or it's an emergency and they just happen to see that they have one. So it's estimated that anywhere from 200,000 to 250,000 of these devices are implanted a year, with an estimation of over a million worldwide. So they're out there. We see them periodically, but the number continues to grow. So it can present us with multiple challenges, as there's multiple manufacturers, there's multiple settings. Patients have different underlying diseases for which these are placed, and so that can vary greatly as well. And the technology continues to develop along the way as well. The technology itself has been around for quite some time, but now we're getting into the era of leadless pacemakers, wireless pacemakers, instead of the typical transvenous pacers that we see. And those can present new challenges to us as well. Management will vary from patient to patient, procedure to procedure as well. And opinions on management are also different. So the point, overall gist is it's variable. And so by having a baseline approach and a basic understanding, we can actually decipher what we need to do. And then emergency situations, like I said, time sensitive. We don't have a chance to look up this patient's records and see what their pacemaker actually does for them. We're going to be looking at permanently implanted cardiac pacemakers and ICDs. So the implanted, you have transvenous, wireless, and leadless pacemakers. And then epicardial pacing is what we typically see on our cardiac rotations. And that's what I feel like we're most accustomed to. So we'll touch on the implanted version instead. So we'll review nomenclature of pacemakers and ICDs, review indications for placement, and then we'll review some perioperative considerations and settings that we need to look at and consider along the way. So nomenclature, you always see the VVI, VOO, things like that. So to break it down, that first slot, so it goes by the order of the letters that are presented. So the first one is what is paced. So is it the atrium, the ventricle, or dual? And then 2 is sensed. So what is being sensed? Are we sensing the ventricle or the atrium for contractions? And 3 would tail onto that. And what's the response if we do have a sensed beat or lack thereof? 4 is rate modulation. Rate modulation isn't something that I was completely familiar with along the way, but it's very complex. There's multiple ways that these devices sense physiologic changes, and it'll adjust heart rate based on those changes. So it's a neat function, but like I'll discuss, it can actually have an effect on our anesthetic as physiologic changes are very swift in what we do. And then 5 is the anti-tachyarrhythmia function, whether it's pacing for anti-tachyarrhythmia therapy or defibrillation. Some devices that are dual, they actually have the rapid pacing in effect while the defibrillator charges to administer that shock. So you have to know what the basic function is of the device that you're going to be taking care of and the patient that you're taking care of has, and what to expect or try to anticipate. So some indications for pacemaker placement. Sinus node dysfunction, so symptomatic bradycardia is a class 1 indication. Heart rate less than 40 with symptoms consistent with bradycardia. Syncope of unexplained origin when abnormalities of sinus function are either present or provoked. You can have them for high-grade or symptomatic AV block, so complete AV block, second-degree AV block with a block of 2 or more consecutive P waves, symptomatic MOVIDS type 2, or asymptomatic with white QRS or chronic biphasic block, or symptomatic MOVIDS type 1. So pacemaker functions. You can have pacing of multiple different levels. So atrial pacing, if you have an intact AV node, atrial pacing might be an appropriate function, as it can the atrial impulse can travel through the AV node and lead to ventricular contraction. Ventricular pacing, you'll see it in patients with AFib with a slow ventricular response to help coordinate or improve timing of ventricular contraction. AV pacing, if you have a patient with AV block, it'll help to coordinate atrial and ventricular function to optimize cardiac output. And then there's biventricular pacing or cardiac resynchronization therapy, which is a lead placed through the coronary sinus. So if you have a patient with a left bundle branch block. If they have CRT in place, it'll help to time that left ventricular contraction to optimize cardiac output. And then, like I touched on earlier, rate modulation, it senses physiologic changes and it'll adjust heart rate based upon those settings. So sometimes it'll have it'll be programmed by whoever placed the pacemaker. So it can sense, some will sense metabolic changes, pH changes, changes in CO2, might detect a change in respiratory rate as an increased demand. So effectively it tries to adjust the heart rate to match whatever stressor that the patient's under, whether it's an activity of daily life or in the event of surgery. If we increase the respiratory rate, it may increase the heart rate. So it's a variable setting. And then asynchronous is AOO, VOO, DOO, where you have pacing, but we're not sensing anything. And usually you'll see that in AV block, asystole, and that's the setting that you'll see coming off bypass typically. So some indications for ICD placement. Hemodynamically significant VTAC, VFib, Brugada's, infiltrative cardiomyopathies, and then you have more recently in the realm of ICDs, they're now used for primary prevention of sudden cardiac death and hypertrophic cardiomyopathy post-MI with an EF of less than 30% or in the presence of cardiomyopathy with an EF less than 35%. And it's important to know why you have these ICDs in place. And that's one of the things that I found very useful along the way is to just understand what it's there for, and that'll guide management. So the preoperative approach, there's multiple different ways you can approach this, and I looked at the ASA advisory. I took multiple papers and tried to consolidate it down into what are the things that are recommended or advice that we do. And this is a way to just obtain information and try to come up with a plan. So first of all, does the patient have a pacemaker and ICD? It can be as simple as look at the patient if you don't have records, and that'll come come into play and be important in emergent situations. What is the function of the device? So like I touched on earlier, different manufacturers have different settings. Lead placement's important, and then you have to know about the settings that these patients have. You have to know what happens with magnet placement and what happens when you take it off. Previously, not all devices would resume their initial function when the magnet was removed. There was a software update in 2009, so that's less likely to happen, but there's still patients walking around with some of these pacemakers in place, especially if they don't have follow-up. They may not have had them changed. And then, are they pacemaker dependent? You can find this information by looking at the patient's chart, looking at old EKGs. If they have pacer spikes in their EKG, there's a good chance they're likely pacer dependent. And then looking for the indication. If they have sick sinus syndrome, something along those lines, they're probably pacer dependent. And that'll be important too, because the last thing you want to do is inhibit the function of the pacemaker. Remove that, because then you don't have heart, obviously. It's also recommended that you get a cardiology or an EP consult to reprogram the pacemaker ICD for elective cases. So it's recommended that a pacemaker be interrogated within the last 12 months and ICDs within the last 6 months. This can help with deciphering the function of the device, reprogramming it to having the appropriate settings for the surgery, and they're great with coming up for ways that we should manage our patient intraoperatively. You can also disable the anti-tachyarrhythmia therapies as well preoperatively. And then don't forget to discuss post-operative management as well with the cardiologist or electrophysiologist, as some of the settings they disable might need to be reactivated in the post-operative setting. So the intraoperative approach, the big thing is electromagnetic interference. So what is it? It's any device that emits a frequency between 0 and 10 hertz. It can interfere with the appropriate function of the device, but it can also permanently damage the device. So some of the things that we have to worry about is inappropriate triggering of anti-tachyarrhythmia therapy, so we can inappropriately deliver a shock. Some pacemakers, especially in pacemaker-dependent patients, may stop pacing if there's a sensed change from this interference. So it's important to consider that as well. What can we do to minimize electromagnetic interference? So some of the things that can interfere, some procedures, radio frequency ablation, MRI, DCTs, a lot of those can have an effect on them. And then electrocautery, which is used intra-op a lot. So you have to consider the site as well. So the site of the surgery matters. Anything that's within 6 inches of the generator can cause damage to the device or interference. So typically people think infraumbilical procedures are less likely to cause interference. And the placement of the Bovie pad should be distal to that or away from the actual device to try to prevent any sort of interference or damage. Some of the other strategies, bipolar electrocautery, I don't know how many times I've requested that. I never got it. I'm sure somebody else has been successful in here, but that's something to consider. And if you don't have the ability to get the surgeon to use bipolar electrocautery, short bursts with intermittent usage will actually help to prevent any appropriate dysfunction, especially in ICDs. ICDs usually need to detect tachyarrhythmias for about 10 seconds before actually administering a shock. And then, like I mentioned earlier, placing the grounding pad appropriately. So, intraoperatively, it's also recommended ASA monitor placement. I know that sounds obvious, but with all the interference that the electrocautery can have on the EKG monitors, it helps to decipher the actual underlying pulsation and rhythm. So you can look at a pulse ox or the arterial waveform to actually see what is going on despite interference. And then have a magnet available. Magnets, it's not recommended that you put them on for every case. It's not a fix-all, but there's definitely times that you need to consider using one. That would be consider the position of the patient. Are they going to be in prone or lateral? If I need it, am I going to be able to reach under the drapes to place that magnet? So that's one thing to consider. So if you're going to have trouble putting it on and you may need it, you might be better off placing it beforehand. If you do need to place a magnet or if the ICD function is inhibited, place defibrillator pads, which makes sense. Do that at the beginning. And then, like I mentioned earlier, not all ICDs will resume the same function when the magnet's taken off. So just try to know as much as you can about this device before going into it. One other thing, magnets, if you have a magnet in place and you can reach it, if you run into the situation where there is a tachyarrhythmia, you can take the magnet off, and if it resumes function, allow that to the actual device to administer the shock. That way you're avoiding those external defibrillator pads, which can damage the device. And these things are made to deliver that shock. So it's recommended that you try that first. If that doesn't work, then administer a shock through the defibrillator pads. And I'll talk about placement of defibrillator pads to try to minimize damage to the device as well. So identification of the implanted electronic device, manufacturer, and other important information can be obtained in many ways. So ask the patient for a card if they have it available. Look at patient records. Obtain a cardiology or EP consult. The other thing we can do is look at a chest x-ray, and I'll show you a chest x-ray and some of the things that you can actually see that'll help you identify the function of the pacemaker ICD, or to find the manufacturer, so at least you can try to figure out what's going on with this device. And then placing a magnet can identify pacer type, but you'll see, I'll show you a table that'll go over not only by manufacturer, but by battery life. So the change when you put a magnet on pacemakers can vary from manufacturer to manufacturer battery life. Sometimes you won't have anything happen, and then you don't know if the battery's dead or if the device doesn't function. So it's really interesting just to look at the changes that are preset in these devices. And then placing a magnet, sometimes some models of ICDs will beep when it becomes disabled when a magnet's placed. So this is that table I mentioned. You can see Boston Scientific sets there. So if you place a magnet and you do get a response, the BOL is the beginning of life. And then ERN and ERT are looking at different points of that battery life, and that looks at time to replacement. So as the battery life dwindles, the actual response to magnet placement will change. So it's difficult to actually say, I put the magnet on, and the backup setting was that it paces asynchronous at 100. And you'll see Boston Scientific and St. Jude are the same. So I think it's important to know that placement of a magnet isn't reliable. You'll get a different response, and some of those responses are also set by the cardiologist that implant these devices too. So some of them may inhibit the ability to actually have some of these different settings, like asynchronous mode. So some of them will not be able to do that based on magnet placement. And then if you're at the end of life, it's extremely variable what will happen when you place that magnet. So further identification, you can look at the chest x-rays. I'll show you some of the different manufacturer labels and then what the leads look like. I try to find an x-ray of all the different leads so you can kind of see them all in one. So these are different images of the actual generators. So where the arrows are pointing in A, B, C, and D are the different manufacturers. So A is Medtronic, and that's their symbol. B is Boston Scientific, C is St. Jude, and then D is Biotronic. And so they all have different symbols. So by looking at these, you might be able to figure out the manufacturer. If you have time, you might be able to actually call the manufacturer with the patient information and try to figure out what their settings are ahead of time. And then in this chest x-ray, there's multiple arrow signs. So the black line is pointing to the atrial pacing lead, and then you can see that they have a thick coil down in the RV, which is the defibrillation coil. And then just above that with the big V-looking arrow, that's in the coronary sinus. So you know this patient has resynchronization therapy abilities in their pacemaker. So that's the way to decipher exactly what you're looking at when looking at the imaging. Is everybody able to see that? So I try to think, in an emergency situation, we don't have time to plan, what can you do? So these are my thoughts. So place external defibrillation pads in the appropriate position. So AP would be the way to place them. That way you're not directing the current if you need to defibrillate through that device. Look at chest x-ray if the time allows, which you probably don't in the setting of a trauma. Set up your monitor to detect pacer spikes. If you see pacer spikes in the in the P wave, you've got atrial pacing or AV pacing or D pacing, depending on where that spike is located. So you can get some information there. And if you do see spikes, they're dependent. So that'll give you that information right away. Consider the surgical site. Try to do the same thing with the Fobi pad and intermittent electrocautery, which may be difficult, but do your best. And then use your arterial line or your pulse ox to look at the underlying rhythm and have a magnet available, especially if you don't know the function. And briefly, I just want to mention some of the newer ICDs. So this is a very busy slide with way too much information, so I want to just break it down. So these things, wireless implantable devices, they implant them in the RV. They're super small. You don't require placement of a generator, so you don't have the pocket placement of the generator. So it's helping to decrease the risk of complications from that pocket placement, for one. They're placed through the femoral veins, so if a patient has some sort of anatomy or DVTs in their subclavian veins, you can still place one of these pacers, and somebody that's super sick may not be amenable to transvenous pacing. So just a brief thing. So you have the micro and the nanostim. The micro is Medtronic's. That one is currently being placed. And that the overlying theme of this is success rate of implantation continues to get better with placement of these. And as providers get more experience with placement, they're having less complications, myocardial perforation, things of that nature. So they're getting better at placing these things. I try to look up what happens with these intraop and what can we do. There's very limited information about trying to manage these. You obviously can't see if the patient has one, so it makes it a little bit more difficult. But these things will not change with magnet placement, so you actually need somebody to reset the pacemaker if you're going into surgery on a patient with one of these. So that one definitely needs a console. And then there's the nanostim, which was actually recalled. The numbers on that one were good as far as implantation and complications, but it was due to premature battery failure, and then there's a little docking button on the back of it that is for retrieval, and that's what it's designed for, but some of those are breaking loose, so they were removed and recalled. So you won't find any of those at this time. And just a picture so you can see how small these things are. They're tiny. And then there's wireless pacing, which is a subcutaneous generator that uses ultrasonic acoustic energy to send impulses to the receiver to generate electrical impulses. And this is more just to make you aware that these things exist, and it's not just the transvenous pacemakers. These are my resources. I tried to get as much information as I could and come up with just a good overall, what should I do type scenario.
So if they switch to all of these wireless devices, does that mean job security for Dr. Algren? Are we removing all the in-running wires?
So they've been successfully removed. So even though they have a battery life averaging about 12 years, we haven't got to 12 years yet, but they have been successfully removed in the past. I don't know what they'll be like in 12 years, whether they'll be scarred in pretty good, or what the situation looks like that with removal, or if they'll find that they'll just implant another device. I don't know if you know the answer to that.
Be pretty unpleasant.
Yeah, hard to say. I mean, obviously, depending upon long-term results, will determine, what we're doing. Obviously, lead extractions have been around for a long time, and we'll continue to do those as people continue to have complications from that. But you flip back to your slide. That's something like a 17% perforation rate on your last slide. There you go, 18% myocardial perforation, right?
Yeah,
Seems
and that was on the wireless.
Is that like one patient though?
seems rather.
It's like 1 in 5 people on perforate.
high.
It was only
That one-
N of
that one I
17 before
I
you're done.
originally was going to talk more about these, but then the one that seemed to be most prominent was the micro. So I figured I'd spend more time talking about that versus the.
Well, I congratulate you for trying to tackle a very kind of confusing topic and something that you're right that residents do struggle to kind of wrap their head around and then keep it around them, right? You can almost have it at certain points in your residency, but then you don't see a patient with a CIED for a long time and you kind of forget, like, how am I supposed to algorithmically go through and manage this one patient? One question for you, though, because this is a question that comes up all the time, is why don't I just put a magnet on this guy if I am unsure, even in an emergent setting?
Well, because it's so variable, what could happen when you place that magnet?
Yeah, what bad can really happen if you just put a magnet on somebody that potentially is not pacer dependent?
If you could,
So
if you put it on, you could potentially put them into an asynchronous mode. You could have RLT.
Yeah, exactly. Right. I've seen that actually multiple times. And then you've got a whole nother problem that you're dealing with that you just iatrogenically created. Right? So it does help you out to do your due diligence and know what potentially is going to happen if you place that. You know, if it's an ICD, most likely it's just going to turn off the tachyarrhythmia function. If it's just a pacer, most likely it's going to put it in an async mode. But you're not 100% unless you actually do your due diligence. So we reserve that for kind of the emergent scenario. And on our elective cases, we should have a little better preoperative plan in place.
Yeah. And I get to blabbing and I forget certain points that I want to mention. And one of them was that in an ICD that has pacer function, putting the magnet on will disable the defibrillator, but typically the pacing function will continue.
Question. Did you come across anything in your reading where they look at closed claims or any other demonstrated complications of EMI on the function of these devices? It's, I don't see really the prevalence of those things happening, and so I often wonder, it's a theoretical risk, but how in practicality, how likely is it that you're either damaging the device or that the EMI that's being delivered through Bovi, for instance, is causing the defibrillator to go off?
Right.
Did you come across anything like that?
I didn't, and now that you mentioned it, that would have been something that would have been really good to bring to this talk.
You know anything?
Yeah.
I mean, it seems to me like it's sort of like aspiration, right? It's like such a rare occurrence that you'd have to have a tremendous population of people with these devices to see one event, right?
I'm sure that the manufacturers have to put that in their literature to say this could potentially damage it, even though in real life it's probably never going to happen. But just as a CYA for them.
And most of the pacemakers are AV pacemakers today. So even if you put the magnet on, it's AV pacing. So you are not doing RLT phenomenon because it's basically pacing from the atrium. So it's getting less and less. You have any kind of major effect, even if you put the magnet in.
One of the instances that I see this, because I do a lot of spine, you see this more commonly in those patients because they're prone. If you're doing a cervical case, thoracic case, EMI obviously is going to be something you have to think about because they use Bovi a ton for those cases. And you can't really get a magnet over the device because it's right on the chest pad. So those can be very problematic patients to take care of. So you have to really think about that. Great job. You guys are done. Thank you.
And she put